All right, it is 1 o'clock on the dot. We'll go ahead and get started. Good afternoon. I was about to say good morning. I said good afternoon to my morning group this morning. I just got back from Leading Age National yesterday evening, and it was actually combined with the Global Aging Conference, which happens once like about every 5 to 7 years. So it was really neat. I got to hear from folks in the UK and Australia on different dementia and memory care models that they're doing in their countries. So I've got some exciting stuff to share down the pipeline here. But for those that don't know me, I'm Elise Piscitelli, the Health Center Administrator. And this is Kayla Pearson.
Kayla Pearson, I'm the Admissions and Transitions Coordinator for the Health Center as well.
And so we started this kind of healthcare discussion series in combination with the Health Services Liaison team that we work closely with. And we've called it Conversations with Healthcare. And we let you determine what you would like to hear from us. So last time we met, which was in September, and we do every other month, I should share. We rotate with Dr. Stowe and Emily Hafner on their series. So the last time we met, we heard from folks very clearly that you'd like to hear about what does it look like to transition to the health center, whether it's a temporary stay or a permanent stay, what does that look like? So Kayla's done a great job in her role putting together this presentation specific for this for you today, different from the health center tours, but some of the things you hear in here you may have heard on the health center tours. So please enjoy, and then we will be happy to answer any questions at the end.
Well, good afternoon. Like I said, I'm Kayla Pearson. I am the Admissions and Transitions Coordinator for the Health Center. I also served as the social worker for 3 years prior to taking this role. So I'm very fluent in the Health Center here at the Pines. We've had a lot of changes over the last 4 years that I've been here, but all fantastic, good changes. So there might be some different items that we go over today that were different 4 years ago for a transition to today. But if you have any questions, please just raise your hand and I'm happy to answer those as well. I'm gonna have the PowerPoint slide up, but I'm not gonna read verbatim through it. I'm just gonna kind of talk about the processes for you guys. But to start with is our levels of care. I just wanted to make sure that everybody knew what care levels we offered within the health center. So usually the first step from independent living would be assisted living. So you'll see support with some daily activities, medication management, programs and meals you'll have there. And then next is memory care, so specialized care for individuals living with Alzheimer's or dementia. And then healthcare or long-term nursing care. We use each language interchangeable. And so that's 24-hour nursing care for more high acuity needs for residents. So to start, we'll start with temporary admissions to the health center. So I put here, why would I need a temporary stay in the health center? I listed out a few different topics of why you would need a temporary stay. Everybody's different. You might just need a stay because you had a fall, you might have the flu or pneumonia, you had a planned surgery that came up. So that's different for everybody. Their length of stay, that's also different for each person. So I'll use a planned surgery as an example. You have an upcoming hip replacement. So when you find out about that upcoming hip replacement and you know that you're gonna need a higher level of care after the surgery and you want to come back to the health center here at the Pines, you would reach out to me and you can find my contact information on Pines Central, and we can either email, call, meet in person to talk about what that process would look like. So I'll find out when the surgery is, what the time is, where the location of that is at, and then we will talk a week prior to the surgery. I'll find out who's transporting you to that appointment and back. And then usually the day of, I'll contact that person who's with you to see how you're doing, if you maybe need to stay overnight, or if you'll be coming back that day. We'll have the room set for you when you get here. And then the nurses will start their care once you get here. We can initiate therapy services once you get here. The medical director or nurse practitioner then can see you on the next business day that they're here to lay out the plan of care. We'll have an admission care plan meeting with you too within the first 72 hours just to touch base with the whole team So you can meet everybody, get to know them, and we can answer any initial questions, or if there's any discrepancies with medications, we can do that too. And so a hot topic that I've had during the tours is the medications. Prior to Elisa's leadership, we did not take any medications from your independent living accommodation. That's changed. When you come to us for a temporary stay, bring your medications from your apartment, and we'll just ask for a medication list, just so we know the dosage and the timing. We'll put that into our system. We'll either administer it to you or we'll let you take it yourself. Either way, we just ask that they come in the original pill bottles with your name on it. We don't want to bill your insurance twice, so if you just got a refill and then we go ahead and order it through our pharmacy. Once you run out, though, we can then order through our pharmacy, which is Neo Medical Group, and we'll bill that to your Part D Medicare plan. And so I laid out here different goals of care as well, which you'll see. We talked about length of stay, and then to go off a length of stay a little bit more. So temporary transfers into the health center. Most of you know when you sign your resident care agreement to come into the Pines, you get 14 days at no additional charge to you. And so you'll pay your independent living rate during that time. And then between day 15 and day 104, we'll stop charging you for the independent living rate, and you'll pay just the health center rate. And so your independent living accommodation won't go anywhere. We'll just hold it. It'll stay as it is. If you need to go up to your accommodation to get any clothes or anything like that, one of our team members can take you, or we can just go if you give us permission. If you don't have family in town, we can do that too. And then after 104 days, you would pay both the health center rate and the independent living rate. And the reason why that is because we want you to make a decision what the next steps will be for you, whether that be staying in the health center permanently, returning to independent living with some additional care. And so we're touching base with you constantly during your stay, whether it be 4 days or up to 104 days, determining what the discharge plan will look like. And so you get it reset every January 1st, your 14 days. So if you use 7 and you have 7 left over, you don't get to roll them over, unfortunately, but each year it's always 14. And so another big point, so if the room is being held for you all while you're here and you're out at the hospital, the room's going to be charged to you because your stuff is in there. What we like to do is contact you or whoever's with you if you had to go out to the hospital while you're with us. If you're here for a temporary stay, I'll hold your stuff in my office. Elise will. It'll be in a safe place. So they're not charging you for the room while you're gone, because we want to be good stewards of your resources and not waste your 14 days if you're not with us. And so then that does not include the ancillary charges, so maybe like a hair appointment and things like that. But it does include your cable and your internet and your landline is all included in your room there. So this is a big question that I get in my role, how to determine it is time to permanently transfer to the health center. So I listed out some overall things to look for, whether it be for yourself, your loved one, your neighbor, or your friend. And of course, it's different for each person, what may change for them. It could just be cognition, it could be physical, it could be both. So I wanted to give these to you all just to have in the back of your mind, to just pay attention to for each of you. And I was talking with Miss Ann Jerens earlier, and she said, who do I talk to if I am concerned about my neighbor? I'm concerned about myself. And that was a great question, and I'm glad she brought it up. So you have Emily Licavoli, who is your independent living social worker. She started in July. Her and I work hand in hand together regarding transitions into the health center. So if you have concerns about, a loved one, a friend, or even yourself, you can always talk with her first. Bill Burrow, of course, too. He's an advocate for you all as well. And then they will communicate with me if they're thinking, someone, just keep it on your radar. Someone might need a transition. We just want to make sure we're set up for success for you, so we communicate together. And so sometimes Emily and I will meet with residents together to go over the different levels of care with their families as well, and them. So that is, I wanted to make sure I share that there is some cross collaboration always, usually on a daily basis with the independent living team and then our team in the health center as well. So I wanted to break it down even further. So what indicators to look for assisted living? And so listed out here would be things that if you saw these things with yourself, your friends, that would be a good move or good time to move to assisted living. And so assisted living, like we said in the beginning, has your medication management, minimal assistance with activities of daily living. Your meals are all prepared in there for you as well. And then the next one is memory care. And so different indicators here for memory care, more cognitive wise, less physical needs, but more cognitive needs for folks. And you're also, and we did this dementia panel last month, and we talked about the caregivers and also looking for out for the caregivers as well, and if they're fatigued too while caring for them. And then your indicators for healthcare. Healthcare being your highest level of care here at the Pines, and when you might need that. If you're coming for a temporary stay, this is when you'll come to healthcare, is because we have the highest staffing ratios in healthcare. We have the rehabilitation services in healthcare as well. So we want you to utilize that when you are there for a temporary stay. Even if you don't need all of that assistance, it's there if you need it as well. And so I'm going to backtrack a little bit because I just wanted to go over those things first. But going back to determining it's time to move permanently to the health center. So we'll have those conversations with you. It's good to have them early rather than later, if we can, as someone progresses through the continuum. And so talking with myself, talking with Emily, and we'll talk about which level of care might be the best for your loved one or for yourself. And those indicators are really what we look at to determine that appropriate level of care. And so if I reached out to you and I was like, hey, we have a room in assisted living and you are next on my list to call, I would reach out to you. I would give you about 5 to 7 business days to go ahead and make your decision to move in. Some people already know, yes, I'm ready to go. And some people do take that full time, which is fine. And I can meet with you throughout those couple of days to review it. We can go back through and look at the different accommodation too to determine if it's a good move for you at that time. We then have an admissions review committee that meets every week, and we talk about folks who are transitioning into the health center, each level of care, and we just review with the medical director. Elise is on that as well, the whole health center team, independent living. And we just go over all the medical information that you'll provide to me. So most people pull it off for me from their Atrium portal, their Novant portal, and we'll get your medication list, your doctor's notes, all those good things, all the tabs on there. You'll print all of it off and give to me, and I'll give it to the medical providers so they can review that. Again, so they're prepared for you before you get there. And then we'll set a date for you to move in. So we can say November 17th, you're going to move into assisted living. On that day, you'll have movers usually that are going to bring all your stuff into the room for you. And then the nurses will come in and they'll do their assessments. They'll review medications with you as well. And then you'll be transferred in. You'll have 14 days to transfer out of your independent living accommodation at no additional charge to you. If you need longer than that, that's completely fine, but they would just start charging for the room that you're in the health center, and then also the independent living accommodation. Most people take between 14 and 30 days that I've learned to transfer out of their independent living accommodation. And so talking about pricing. So here's your chart for the pricing if you were a permanent admission to the health center. So it's broken down by contract type of when you sign that resident care agreement. And I can always go over this with you one-on-one if you need to as well. And so we have it here for assisted living, memory care, Healthcare Brown, which is our original healthcare neighborhood, and then Healthcare Malden and Wilson, which is the newly constructed neighborhoods that opened in 2020, 2021. The only reason the cost is different is just because the accommodations are different there. The same level of care is provided though. Memory care is at your highest rate for the daily rate because there's an activity fee included in that as well, which is already rolled into the daily fee, so you don't see it like as an additional charge because there's more activities in memory care on a daily basis compared to assisted living and into healthcare. So those were the big things that I wanted to talk about. Questions right now? Go ahead.
Of this,
Yeah.
of that.
Ms. Ross asked if we can get a copy. Yeah, I can do that. I can post it on Pine Central too, the whole PowerPoint slide, so you guys can have that available to you as well. Yes.
How do you manage wait lists?
Yeah, so good question. So prior to me taking this role, how do we manage wait list for all the different levels of care? So before I took this role, there were no wait lists for the health center. And I think that there's more so a wait list now because we've been doing the tours, we've been doing these conversations with you all. There's been more of us coming over here just to meet everyone in independent living as well. So right now I have an assisted living waiting list. And the way that works is if you call or your family and you meet with me and you say, hey, I think I'm going to be added to the wait list. There's no extra fee. There's no change in your contract or anything. I simply just have a chart of folks who are on that list. So we go off, it's all in order. So if you were first on the list and I called you and told you there was something available and you told me no, you would stay right there in that spot. Just like how you moved into the Pines, you would stay in your spot that you're in. And then I would just move on to the next person after that until someone told me that they were ready to move in. For healthcare, it's a tad bit different because I do have some folks who want to be added to the healthcare waiting list for the new neighborhood. They want to wait until there's something available in the new rooms, which is fair. You know, you want to have a different accommodation, and I have a list for that too. And then I also have a list for folks who want to transfer maybe out of Brown into the Malden and Wilson neighborhoods, which are those new neighborhoods as well. Memory care, I haven't had a waiting list since taking over this role yet, but it would be the same process for that too. Good question.
How much furniture are people allowed to take to assisted living?
Yeah. So the question is, how much furniture are you allowed to bring to assisted living? As much as will fit in there. So the only thing that stays in there would be the bed. We have to keep the bed in there because it's an electric bed. It goes up, down, lifts the feet and the head in case of an emergency, and it's on wheels. So if it had to get out, we could move it as well. But there's a standalone wardrobe in your assisted living room. That can come out if you want it to come out. I've had some people take it out and some people keep it in before. And then most people will bring in a chest of drawers, maybe an entryway table, the TV. You can either mount it or you could put it on a TV stand. I have people bring desks in or like small kitchen, like the circle small kitchen tables. They'll bring those in, a recliner, a bedside table. And then anything you want to hang on the wall, you can hang on the wall as well. As long as you have a clear, safe walking path for if you have an assistive device, it's fine to have it in there. Now, if we need to move things around once you get in there and that works better for you, we can do that too. But those are the big items that people will bring into their rooms. Yes. Yes, some people will bring in mini fridges into their rooms if you would like. And also like maybe Keurigs or a little small coffee pot or something, just not a microwave because that's a fire hazard. But we have microwaves on the neighborhoods that you can use too. But yes, the little mini fridges as well.
Yeah, a big difference in the health center, and some of our folks will put decorations outside their front door to their rooms. We cannot have a lot of items in our hallway due to fire. We have a stricter fire safety code we have to follow in the health center. Same thing right around this time of year, we cannot have live greenery in the health center because of the fire hazard associated with that. And so there's some differences when it comes to those types of decorations. But for the most part, we really encourage folks to make it your own because it's your home.
How much of a wait list do you have in assisted living? And do you take people from the outside, and are they on the list as well?
So to the first part of the question was, how many people do I have on my assisted living waiting list? Internally, meaning independent living residents who would like to transfer, 14 right now. And then I do have she asked about an external waiting list and if they're on that too. It's a completely separate waiting list for them. We haven't taken anybody from the community since last October because our waiting list became from independent living. And that person was actually on the future resident list for independent living, but then bypassed through independent living to assisted living.
Mm-hmm.
On that waiting list, I have 25 people on the external one, but we don't take any direct admissions right now because we have such a long waiting list for our independent living residents. We will always prioritize you all prior to looking out into the community.
Mhm.
And the amount of people that we have right now that are from the community are
In assisted
assisted living.
we have four,
Four.
but two of those, like Kayla shared, two, if not three, were residents that maybe signed a resident care agreement for independent living, and during their 60-day move-in, we determined they needed a higher level of care, and so they're still considered a direct admission because they were not in independent living beyond that 60-day time frame, and so they came directly to assisted living at that point because we had an available bed. If we did not, we have had it where folks would have to look elsewhere during that time frame. Yes. Sorry, you had.
Did you say there's a waiting list for Brown?
No waiting list for Brown right now, just Malden and Wilson. So Malden and Wilson are the newer neighborhoods. And the reason that is because the rooms are larger there. And that's why folks would like to transfer to those rather than there be a wait list for Brown, which are a little bit smaller.
And it would seem like sometimes someone would really need to go to Brown right away. Is there a procedure for that if there were a waiting?
Yeah, if they were waiting for the Malden or Wilson neighborhood and they had an urgent need and needed to move into healthcare, so then the resident would transfer into Brown. And then we also have our overflow rooms that get relicensed every 60 days, that at least relicense every 60 days. There's 7 rooms, which are additional for us for overflow in case there was an influx of admissions and we had people who had illnesses or a bunch of surgeries all at once. In May, we had so many surgeries. I couldn't believe, it's like everybody scheduled a surgery in May, but we got to utilize those overflow rooms, which was good because that's why we have them for you all.
If you're in healthcare temporarily, say you have a hip replacement, do you have to wait until Dr. Stowe releases you, or can you leave anytime?
So we want to recommend that you let the provider see you. As a resident, right, though, in the health center, we can't hold you in the health center. So if we will help you come up with a safe discharge plan, though. So if you're like, I'm good, I don't need to see Dr. Stowe, I started therapy, I feel fine. We're really going off your judgment as well and your family's judgment because you know yourself the best. And so we can maybe recommend, well, how about you just get someone to come in your apartment and help you with a shower twice a week or something like that. And then we'll check in on you as well. The independently living team will do that too. But no, we can't hold you if you're ready to go.
I saw the term sundowning on one of the slides. What is sundowning?
Good question. So sundowning is a term that's used for someone who has an Alzheimer's or a dementia diagnosis, or even Parkinson's, cognitively impaired diagnoses. And so it's a term that neurologists will use, and we've started using them in long-term care too. And as the sun starts to set, someone might become more anxious. And that's just maybe due to the change in time. It's getting closer to nighttime. So people will change. And so it could be that someone might wander more, or they might have more questions. They might need more redirection at times and reminding. But that's what that means.
Are all of the assisted living rooms the same size?
No. So assisted living, there's a few different floor types from when they opened assisted living originally, and then they did an expansion well before I got here. I think it's been 10 to 12 years ago, and there's larger rooms where if you know where the nurse's station is in assisted living, those rooms in that corridor are a tad bit larger in square footage. And to answer another question that I get a lot regarding that, if you move in and you're in one of the quote unquote smaller rooms and you wanted to move to a larger room, and we didn't have anybody on the waiting list and no one wanted to move in, we could transfer you to one of the larger rooms if you still wanted to do that, though.
Coming around.
I understand that some of the rooms do not have private showers. Where are those rooms?
They are in memory care and then healthcare brown. So they have the spa room in the neighborhoods. And so we recently renovated those last September just to be more modernized, to be nicer. If you haven't been on the tour, I would encourage you to come so you could see it as well. But it's always private for residents unless they need assistance from a team member. Then a team member will be in there with them for that.
As always, thank you for your presentation. You didn't mention Medicare, and everybody in the room is curious to know, Medicare doesn't cover the room rate, but could you say something about how Medicare does interface with all this activity?
Sure. Let me take it. Yeah. So that is a big question that we receive is, what does Medicare cover in the health center? And that is one of our slides on the health center tours. So we do not participate with the Centers for Medicare and Medicaid. The Pines as a whole does not participate. We are not a licensed provider with them. However, all of our contractors, Select Rehab, Dr. Stowe under Novant's billing, all of our podiatry, audiology, ophthalmology, they all are providers with CMS. So they will bill your Part B plan usually, depending on what the service is that you're receiving. Like Kayla shared earlier, pharmacy will be under your Part D plan or your Medicare supplement plan. But for room and board, it is all private pay. If you do have a long-term care insurance policy, they will reimburse for that most often, but that's individualized to your specific policy. And we work with our medical records coordinator, Jan Parson, on filing that on your behalf so that you get reimbursed for your room and board, depending on what your plan is or what your policy shares. Yes. Did that help answer it?
If we have an emergency and go to the health care, how can people in our building, our friends, if we're single and we don't have somebody to communicate, how can those people get information? You're so controlled by HIPAA and all of that sort of thing. So how would we make sure that people, our friends and our residents, can find out what's going on?
So that's a good question, because we get that a lot regarding how do my friends and my neighbors know where I'm at and what's going on with me. So if you were in healthcare for that temporary stay due to an emergency or wherever it may be, we would talk with you first and find out, would you like anybody to know if they ask us that you're here in the health center? Do you want them to know which room you're in? And if they ask any questions, what do you want us to tell them about your medical status? And most people will say, yes, you can tell my neighbors and my friends that I'm here in room 107 and that I, had a hospitalization. I just need some extra help. And so it's always up to you what we can share. We won't share any more than that at all. But if, we do have your HIPAA medical form that you do fill out, and we go off of that who we're calling for emergency emergencies and updates along with you. But we know your neighbors care about you and your friends care about you. And if you tell us no, then we're of course going to keep that confidential and tell whoever's asking that they will have to wait to reach out to you or a loved one to find out what's going on.
Clear before we're there, like if there's something you fill out and have that in healthcare.
Yeah, you can fill it out. You can let Emily Licavoli, the aisle social worker, know your wishes ahead of time. We do see a lot of times it may change based on the circumstance. So if there is a sudden diagnosis that you receive and you're working with your family through that process, or whoever it may be that's closest to you, a lot of times we'll hear folks say, wait to share anything with my friends and neighbors until I can process what's ahead for me or what I'm going through. And so it may change. So if you fill that form out when you move into independent living or annually, something could change during that year that you choose to change. So we like to confirm on the healthcare side, when you do come over to us, are these still your wishes? Just like your advanced directives, do you still wish to be a DNR or a full code? Because it can change. I do want to back up to the 14 days and tie that into the Medicare coverage. The 14 days, and most often in a CMS environment, in a community that is CMS certified, the average length of stay for a Medicare Part A coverage or stay used to be 10 to 14 days, and that was about 5 to 7 years ago. Now the average length of stay has decreased to 7 to 10 days, and then you are being issued a notice of Medicare non-coverage, where Medicare is saying we're no longer going to pay for you to be in a skilled rehab center or a rehab center. Medicare does not pay for custodial care, which is long-term care, that Medicaid would pay for, or your long-term care insurance, or you convert to private pay in a building that is certified under Medicare. So there's confusion. A lot of times folks think that your Medicare Part A is paying for your custodial long-term care, and it does not. It covers your hospital, inpatient rehab care, but not long-term care. And so that benefit of the 14 days, you're actually in a lot of ways getting more coverage. So what we will sometimes tell folks is if it was a diagnosis, say a stroke, and you were going to have a 30-day rehabilitation period that we are looking at after the hospital, we will encourage you to potentially go to a Medicare covered facility, rehab facility, use your 7 to 10 days there under your Medicare Part A benefit, then come to us in the health center after those 7 to 10 days and use your 14 days so you get more coverage, depending on what the circumstance is. Not everybody needs that, but we will work with the hospital to determine what's going to be in your best interest for that. Here and then, oops, sorry.
Like to point out, you don't have a choice whether you want to go to acute rehab. You have to have so many hours of physical therapy, occupational therapy, and speech therapy in order to qualify. So it's not your choice.
For acute rehab, that's the case. For subacute rehab, say in Autumn Care of Cornelius, Huntersville Health and Rehab, they're subacute. Again, you have to qualify. But if you qualify to come to our health center, most often you will qualify to go to those subacute rehab. Acute care, like as he was sharing, is very different. So you do need to qualify differently for that stay. But we do work, right now, we work most closely with Autumn Care of Cornelius for folks that will need longer than 14 days. And it doesn't happen often, but it does happen that you may need that stay.
This is a little bit different, but if the background under the headings was a much darker color, it would be much easier to read the slide.
I just didn't want to trip on it.
I'm going back to assisted living. How many individuals currently live in assisted living? And if I were going to need a bed and I was number 15, how long would you say I would have to wait?
round one. You got it.
So currently there is 30 residents residing in assisted living, and there's 30 rooms in assisted living. And if you were number 15 on the list and you needed to move, how long would that take? So I'm going to say it's very hard to determine how long it is for a room to open. Elise and I have gone back and forth, like, what do we say to people? So I give you a ballpark range that usually every 6 months we see 1 bed turnover. Now, sometimes it's 2 that we have. That is, we give ourselves a little bit of a buffer period saying 6 months. It could be less than that, but it's really hard to determine that. We just try to look at previous years of what our occupancy looked like as well. And if you were in 15th on the list and you're like, I need to move right now to assisted living, I can't be alone anymore. We will offer you to come to healthcare always. That's always an option to you. And we can go ahead and vacate your apartment while you're in healthcare. So then you'll be ready to go to move into assisted living when something comes open.
And we have had that happen where folks are waiting in healthcare because they require that service, and they're waiting for assisted living and then transition from healthcare to assisted living. Like Kayla shared, we look at historically how many move-ins we've had and how many beds have turned over, and the average has been 3 to 4 a year. And prior to that, it was about 2 to 3. Looking at our average age in assisted living, it's a little bit more than it had been, but not by much. Did you have a follow-up?
Okay. Well, given that scenario, what plans are the Pines making to offer additional assisted living beds?
Great question. So we have a master planning task force, and we are working with that task force on what does the additional expansion look like for assisted living. We know there will be an expansion of assisted living. Exact number of beds, we do not have that determined right now, finalized, I should share. And so we're looking at what that looks like, and also assisted living for couples, and having larger accommodations for assisted living where couples could move into assisted living. So that is in the plans, and more to come on that from Vernon and our senior team on what that will look like. But we do recognize we do need more assisted living beds. We do not need more healthcare beds per se. And a lot of communities are actually downsizing on their healthcare beds and adding assisted living for folks to age longer in assisted living without transitioning to healthcare.
Well, I don't have a serious question because they're all been covered, but I do have a wine refrigerator fully stocked. Can I bring it?
Great.
Or do I have to drink it all before I come?
No. So we do have folks that, your life doesn't, there's certain things you enjoy, especially as you get older. And so that does not change. We have orders from our doctor that you are allowed to have alcohol. Now, we do have to specify, because of regulation, how much you can have. And so we do have that, and we can store it for you in a locked fridge in our med cabinets, or you can have that as well in your room. As long as you're responsible to have it in your room, we allow that. And so we did have a funny story where Dr. Beeman thought 8 ounces of whiskey was the same as an 8-ounce glass of wine. And so we had to change that order. That was a few years ago. We could not, we had to educate him. Yeah.
I'm not trying to beat a dead horse, but going back to what Sue asked you, those of us who don't have family and who live alone here, if I fall down and break my neck and they cart me off to the hospital, nobody can find out where I am. And is there any way is there any document or form we can sign that says you can tell people that I'm in Cabarrus Hospital because it happened and they didn't know for a week where one of the residents was? Understandably, but is there anything we can do to?
What I've had people do in the past, and in the health center, so it could translate over to independent living too, is they'll write a document and they'll say, I would like for my neighbors and friends, if they ask where I'm at, if I have a fall and a hospitalization or whatever it may be, that you can give them the information. You'll date it, you'll sign it. We will then, because we know when you go out to the hospital, whether you think we do or not. I'm just kidding. But the hospital will usually reach out to us and let us know that you're there. So then at that point, we can double check with you. You sure you want people to know that that you're here at the hospital? Okay, then we'll use your letter then. So you should put it in your wellness clinic chart with Terry in the wellness clinic. You can give it to Emily and she can put it in there, but that would be the best place to do that. And that's probably the best way to do it because you don't have a legal HIPAA form in independent living really other than your healthcare power of attorney documents.
And I can work with Bill and his team. It's an opportunity for them to create a standard unified form. And so I'll work with him on that for independent living.
Another example of how area reps and neighborhood reps are really handy. If you get to know your rep and your area rep, they might be somebody who could communicate with Kayla or Elise or, just one more way of continuing our community. So you can't give verbal permission?
You can to us.
Okay.
Yeah, we will always accept. Right. Yeah. Yeah. So we can make a process where if it is the standard form that, and trying to be respectful of Bill and his team on making the process that's going to work for them. With us using Point Click Care, our electronic healthcare record, and using it more and more for independent living, that's something we perhaps can put in that electronic care record and have it uniform across the board. Emily has a goal of meeting with independent living residents at least twice a year. And so it could be a touch point. We have care plans in the health center, care plan meetings every once a quarter with all of our residents. So at least 4 times a year, we're meeting with them and their families. We review advanced directives. We go through all of the paperwork we have on file at least 4 times a year. So it could be something that she develops a process similar to that for independent living. Any other questions? I've missed some hands.
I'd like to know what sort of care, what sort of care, I guess is the word. I'm not sure that the assisted living people get. How do you train people to care for them?
Do you want to speak to the training or do you want?
You want to take the first part?
Yeah, so for the first part of, what level of care is provided there, and I'll let Elise speak to the training because she works hand in hand with nursing for the training piece, but for which level of care is provided. So some assistance with activities of daily living. So the biggest ones are bathing, grooming, showering, and then toileting and dressing. And so a lot of the time it's the bottom half dressing that more residents need assistance with. And so we're able to help with all of it. And when their residents are in assisted living, all of the medication management is done there as well. Residents are able to ambulate with a walker or a cane, a rollator, or independently. If they do need a wheelchair for long distances, you're able to use that. But on the neighborhood, residents are using an assistive device or independently. You need more assistance with scheduling appointments and follow-up things like that. That's what our team will take care of as well. And then your doctor's appointments. It's better for them to be on site. And so they'll provide that there to you in your room right on site as well. And so those are our biggest ones that residents need. And of course, the meals. You don't have to go get your meals. They can be served right in your room or they're right there in your dining room in assisted living as well.
Okay, I've forgotten what I was going to ask you, but that's why I'm here. Can we access Point Click Care in independent living? I don't think, Dick had it and I didn't know what it was.
So we don't have a family portal for the point click care.
Okay.
But if you ever want to know what's in it, we can always pull it up and print off anything that you need. And we can do that in the health center as well, either way.
Another thing, Dick was in Wilson, and for those of you worried about showers in the Brown unit, they rarely bathed him in the shower in his room because the floor got all wet. So they took him to the spa anyway. So it really wasn't an issue. And there's a mini fridge in there.
I just want to touch on point click care for independent living. Even though we are developing charts for independent living, it is not going to be as robust as the health center chart would be because we aren't going to have all your medications listed. There's not going to be a medication record, administration record in an independent living because we're not administering your medications. We will have your basic information, your primary care physician, any allergies you have, who's your responsible party if it's not yourself, emergency contact information, advanced directives. So we will have a basic profile in point click care, but residents don't have access to that side, but we can print it out for you if you'd like to see it.
Elise, you want to touch on the training for assisted living?
To answer the training piece. So we do train all of the nursing staff. I'll start with assisted living is staffed with certified nursing assistants, registered nurses, and licensed practical nurses. Industry standard for assisted living, typically they'll have one nurse overseeing the entire assisted living, and then they will utilize medical technicians, med techs, or medication aides in place of nurses because medication aides can also perform ADLs and administer medications. The Pines is unique in that we choose to utilize the certified nursing assistants for the activities of daily living. So they provide your activities of daily living and your nurse performs all the medication, working with the physician on what that may be and also assessments. So we are more staffed than the typical assisted living would be. And we do train the same way. All of our staff are trained the same way. So whether they work in the health center or assisted living, they receive the same training, which basic training is infection control, dementia training, resident rights. We go through pain management and palliative care is a big focus that we're training our team on. Trauma-informed care is a newer concept that we're working on for basic mandatory training that everyone has to go through. And then there's, of course, safety and fall prevention and a lot of stuff that we do on the back end as well. That's annually upon hire, and then we try to stick in additional education throughout the year.
Did you say ADL?
Yes. So activities of daily living is the long term, which is bathing, dressing, toileting, hygiene, anything that you perform on a daily basis. And in short, in the healthcare world, we call it ADLs. Thank you. I should have clarified.
If we wanted to review and update our chart, who do we talk to do this?
To update your chart in independent living, you can talk with Emily Licavoli, the social worker. Rebecca Johnson can also help with this task as well. Or also Terry Murphy has access to be able to do that too. So any of those three ladies are available to you to update any of your records. Yep, Emily Licavoli, your social worker, and then Rebecca Johnson, and then Terry Murphy in the clinic, the wellness clinic.
Please say a word about the tours.
So we've been doing our health center tours since February of this year. They were revamped from what they were a few years ago. So now in the tours, it's Elise and I who present in those tours, and they're smaller. So it's only 6 to 7 people in those tours, and we have them the first and third Tuesday of every month from 10 to 11:30 in the morning. We start with a presentation that's much more detailed, which answers a lot of the questions you guys had today, which were great questions. We tried to nail those down in the tour too. And so we go through all of the levels of care, your key personnel, what a transfer would look like, Medicare, what your room situation would look like as well, dining, medication, and ancillary services. And so then after that, we go on a walking tour of each level of care, and you get to see the neighborhoods. And if we have any vacancies, you can of course see a room too. We had a professional photo shoot done a couple months ago, so now we can include some of those photos of the rooms in the tour so you can see those as well. I leave you with a handout of the PowerPoint slides, the charts, which review all the cost again with you. You get to take that with you, and then I'll follow up with an email to send you it virtually as well. So if you wanted to provide that to your family, you could do that too. So if you haven't come, I encourage you to come. We've gotten really good feedback, and Elise and I have really enjoyed doing them. So I look forward to seeing you guys. The tours are open right now, completely open all of December, and all of the next one in November as well is open.
Yes, you can sign up for the tours on Pine Central.
If your team determines that someone who's in independent living really needs to transition to assisted living or healthcare or memory care, how much power do you have to make that happen?
Yeah, it's so based on the resident care agreement, the Pines reserves the right to force a move, and I don't like to use that terminology because we don't want to do that. And as long, I think Vernon has shared it's happened once since he's been here that they had to tell a resident in independent living they were no longer safe, and work with their family. We choose to take the approach of working very closely with that resident, with the independent living team and the health center team, and of course, Vernon and David and our leadership on how can we keep them safe, but also working with them towards what's the hesitation in the move, and try to get them to a place where they've made the decision and they're comfortable with it. And sometimes it can take 6 to 9 months for that. It can take a long time to develop that trust and that confidence that a lot of times it may be a spouse that's not ready to make that decision for their partner. And so that's really why we are also developing closer relationships with independent living residents, so that you see our faces, you know who we are, we're there with you, whether it's a planned surgery or it's an unexpected stay. You have that relationship with us, so we can have those hard, crucial conversations that may need to be had. But we're a lot of times working very closely with the families and the residents over time. So we really do not want to force a move, and we will work with outside partners too on how to keep you safe and what's going to be in your best interest. But the short answer is it is in your resident care agreement that the Pines can do it. We really don't want to. But there was one situation where it was no longer safe. They did not have family close by, or really any children, anyone that could help support, and that move needed to occur. And what we hear most often when folks do make the decision is, I should have done it sooner.
Did you say outside people or something like that?
So like private duty home care, and so or agencies that can come in and provide assistance that you may need in the interim if you are in independent living. And several folks use that now. We have a preferred vendor list of who we've met with that we believe the way they train their staff and their values align with the values of the Pines. So we work closely with those folks. We're not responsible for their caregivers, but we want to know who you may be working with so that if there is an issue, we can help advocate on your behalf.
And strongly urge you to take advantage of the tours of the healthcare area. They are absolutely incredible, and you'll learn a lot.
Thank you. Thank you, Margo. Yeah, Kayla has done an excellent job since transitioning into her role. I think we've had more connection with the independent living side and healthcare since she's assumed that role, and really on trying to break down that barrier to healthcare and the fear and anxiety that may be associated with healthcare.
The group that we have now is great. So you really need to take advantage of it if you need that help. They are really terrific.
Thank you.
I have a question. Since Early Advantage is up and running, are you holding any beds in healthcare for the eventuality that somebody needs one?
Great question. So with Early Advantage, as part of our application to the Department of Insurance, we had to reserve 10% of our beds in healthcare would be, because they would be considered direct admissions into healthcare when they come to healthcare. And so what's happening is, by natural attrition, our current direct admissions would decrease, because those folks most of them would not need health care within the first 3 years at least. Now, there may be some that do because of something unexpected, but over that 3-year time frame, as our direct admissions decrease, and we're at 36 total right now, which includes assisted living, we will have those beds for the EA members to use.
I just had a quick, someone asked me a quick question over here about visiting hours for anybody, spouses, friends, family. We can't restrict visiting hours. We have suggested hours, but you can come visit anytime that you would like, any day that you would like. If you want to stay with your partner in the room, you're able to do that. Say they have an acute illness going on, you just want to be at bedside with them. We'll try our absolute best to get you a comfy recliner to be in. We'll get you a meal. We'll get you drinks and stuff like that. But we always encourage those visiting hours for you.
Yeah. North Carolina regulation, we can't restrict when families visit or loved ones visit or friends. So the door is always open.
Well, thank you all so much. We're getting